So I did not use AI for my slides. It's going to be super obvious. You guys will see. And I committed to this background and I hate it. But I already was like halfway through, but whatever. So yeah, it was a struggle. Okay, is it moving? There we go. So this is just to say, it's gonna sound like a lot of things, but it's really just some 4 or 5 major themes. I'm gonna focus a lot more on encephalitis because I feel like you guys don't get as much of that as like meningitis. Super, like, since you were a med student, you've been dealing with meningitis, whereas encephalitis is a lot more harder to diagnose and seems just a little more like less practice, for lack of a better word. So, and I'll focus on the pathogens like that are more universal that everybody should know, because otherwise there's like a million of them that, and you guys are going to walk out of here. If I try to tackle all of them, you're not going to remember any of them. So that's the plan. So just a little background on encephalitis. Huge burden to healthcare. Hospitalizations are long, high fatality rates. And even if you don't die, the problem is your recovery and what you struggle with for years to come. A lot of money with hospitalizations and just healthcare associated with it. The last IDSA guidelines on meningitis and encephalitis are either archived or from 2008. There's nothing new since. I'm focusing a lot, which you guys should totally make this part of your repertoire here, but state-of-the-art acute encephalitis. This is a CID paper from 2023. Because like I said, everything else is super old. And there's a lot of emerging pathogens that we have not, are not covered in any of the IDSAs. So. All right, so some definitions. Clinical criteria for diagnosis, again, because we needed some sort of guide. And this is from the International Encephalitis Consortium. So there's major criteria and minor criteria. As you can see, the major criteria, I don't want to read everything to you, but basically decreased level of consciousness, personality change, psychiatric manifestations, more than 24 hours. And just keep in mind, again, I'm not going to go into kids a lot, but for toddlers and infants, it may just be increased irritability and lethargy, as you guys know. And then something that you don't have an alternative explanation for. And then the minor criteria are going to be fever, new onset seizure, focal neurologic findings, CSF, white blood cell count greater than 5, which there's some caveats there, but I'll go into that later. Some sort of brain abnormality on MRI, and then EEG. This is just sort of like a management of acute encephalitis. And the main thing I want you to look at is, do they need to go to the ICU? So you figure in, we're probably not going to be making those decisions, but just respiratory, how are they able to keep their airway, Glasgow Coma scale. And then, but mostly like, look at the things that you're supposed to order. HSV, VZV, Enterovirus, cryptococcal, VDRL, West Nile, and anti. So that's like what we're supposed to be ordering on anybody that you think has encephalitis, right? So that's a really good question. So definitely if they're HIV positive, but there's different crypto and immunocompetent patient that could be valid. There's other epidemiological stuff. So that's a really good question. And I'm going to come back to this. So we're going to just sort of, like I said, fly through this. All right. So first question. Who wants to read it?
Okay. 65 years old woman hospitalized for something. Ultimate status.
Stop sharing.
4 days,
Sorry.
4 days ago, she experienced headaches and temperature of 39 Celsius. Today, she developed aphasia, prompting hospital admission. Her medical history is otherwise non-contributory, and she takes no medications. On physical examination, temperature 39.3 Celsius, blood pressure is 122/64, pulse is 98, and respiratory rate is 18. The patient is unresponsive and premises to sternal rod. The neck is resistant to passive flexion. All extremities move spontaneously. There is no rash. Here we have CSF studies. And then brain MRI show no focal abnormalities or hydrocephalus. The patient is administered empiric therapy with dexamethasone, vancomycin, ceftriaxone, ampicillin, and encyclopedia pending additional tetrazones.
So these are all either from your board review or from older board reviews or some mix-up that have been used in board reviews. Oh, okay. Yeah. So which of the following is the most appropriate next step in management? I didn't make these, so. Yeah. Oh, sorry. Don't need to go back. Sorry. Stay here.
Oh, God. Yeah.
What?
You can't even pressure under 50 in the operative pressures.
Pressure of opening from 50. So that's why
That's millimeters of water, remember? Yeah.
Yeah.
All right. So what's your, right. So what's your final answer? All right. So that's everybody's.
I think when you have high pressure, you need to get CT head to see if there's anything structural.
They already-
Here,
they-
they invest in
But
ultrasound.
they already got it. And there's no like obstruction.
I'm glad I didn't say the usual dumb thing that I say, which is we're going to start with the warm up easy question.
Yes.
I like to build you up and then, but,
Yeah.
but this is only, but like I said, they're just, this is what they do. They're not great questions.
Is it C?
So this is all, yes, it's C. So this is all just to see if you guys were paying attention to this. So, huh? Yeah. Yeah, that's, they want you to have an EEG. If you're suspecting encephalitis, they want you to have an EEG. It can help you with different patterns, can help you identify
Vocality,
Turn-
you think HSV.
certain.
Oh, definitely. Why? 9 times out of 10 it's told me nothing except
Yeah, true.
cool stuff. So
Yeah, that's,
sorry.
they want an EEG. All right. Next question. All right, here we go. It's going to get better. So, 50-year-old man presents with several day history of fever, headache, personality change, progression to confusion on exam. Fever 101. He's disoriented, unable to follow commands. CT of the head without contrast is negative. This is a CSF analysis, as you see there. The cyclovir is initiated. MRI with gadolinium reveals enhancement in the left temporal lobe. Results of initial CSF PCR for HSV 1 and 2 are negative. Patient is now oriented to name and following simple commands.
D.
If anybody rotated with me last month, we talked about that a lot. Why? So it's a PCR, right? Yeah, and early on in the disease, it may be negative. You may not have enough to pick it up, which is different for other things, but we'll go over that.
Also, the multiplex PCR is not as accurate if you do that.
So they tell you to,
That would never.
No, that's not.
Correct.
Yeah.
It doesn't really
Not
populate.
not for HSV, for arboviruses and stuff, it can be.
So that's why I'm asking why C, because obviously if you use your test taking skills, you can cross out a bunch of these things. Yeah.
All of them.
We can't get people to do LPs. Imagine yeah, forget about the LP. Can you do a brain biopsy for us? But yeah. So if you go by both US and international guidelines, you're supposed to literally repeat an LP, get more CSF, and send another HSV PCR. We can barely get the initial LP. So we're left with, okay, I guess I'm treating this guy for 14 days or plus, you know? So, right. But basically, the point is you need more. usually can be negative in the first testing, and then after 3 to 4 days it becomes
So
positive.
the
Yeah.
wait period 3 to 4 days.
Yes, that's what the guidelines say. Huh? To discontinue acyclovir, correct. Especially when what?
The temporal lobe.
Patients improving.
Enhancement.
Patients improving on the treatment, temporal lobe. So in other words, there's a very high clinical suspicion for HSV, right?
Yes.
That's the key there. Why you don't stop the acyclovir. All right, and all the other things you guys correctly picked up on. Okay, so repeat CSF analysis on day 4 reveals that the PCR is now positive for HSV. HSV1. Patient continues to improve, completes a 14-day of acyclovir. 1 month later, he presents again with fever and confusion. This is your CSF. This is your CSF. So the second years that were just at board review,
Yeah.
they always make a big deal about this. So this are CSF studies now. PCR tests for HSV1 and HSV2 are negative. And we get real life cases of this. Which of the following is the most likely reason for his second presentation of encephalitis?
Yeah. First year.
Okay.
So kind.
It's second year, they're like, trolling.
Yeah. Seriously. Trolls.
Going with what? B? No, B?
Yeah, HSV 1 and 2 were negative.
Welcome, Taylor. All right.
I agree. C.
Correct answer.
C.
Yes, the correct answer is C. So can you guys, since you guys know so much, do you guys want to explain that?
Ooh.
To-
That's what we know.
Yeah.
to the first year, since you were trolling?
So autoimmune encephalitis is associated with HSV. It can happen approximately 1 month after the course. They actually it's in the state of the art review, and there was also an episode of Febrile about it. So that's
Ooh, nice.
yeah. Anti-NDMA.
Anti-NDMA.
Yeah.
What's the mechanism?
It's molecular mimicry.
Yes. Wow. That's excellent. Good stuff. Strong work. Molecular mimicry.
I feel like when it's autoimmune, it's safe to just get.
Yeah, I was gonna say. But the fact that you could remember those words, that's pretty on point. But yes, mostly autoimmune. It's like, this looks like this. I'm gonna attack it. All right. So good job. So autoimmune encephalitis following infection may represent molecular mimicry, cross-reactivity between pathogen epitopes and self-antigens. That's all autoimmune stuff. But there's a huge association between herpes simplex encephalitis and this anti-NMDAR encephalitis. So the development of anti-neuronal antibodies, this is huge, right? 25% of patients with HSV, and it typically happens around this time, 16 weeks, right? This one was a little early, but still, it on average is 16 weeks after.
Good question.
So like,
The likelihood of getting autoimmune.
So, say that again. Earlier treatment, meaning if we took too long to start it. Yeah, I don't know that there's.
But it depends how early the patient presents also.
I'm just thinking of similar like autoimmune after is like, encephalitis after. Give the.
Right.
Yeah.
Yeah. I honestly don't know if there's been any studies on that time frame and when it's actually happening. The duration of acyclovir is extended in certain situations, right? So immunocompromised patients, if they're not clinically improving right away, you already have an HSV PCR positive. So all good thoughts. All right, so most common fatal sporadic encephalitis in the world. That's why we're focusing on this. I think it's really the one you really need to know inside out. In the US, 10 to 20% of the 20,000 annual viral encephalitis cases, mostly older adults with a median age of 57, which the older I get, the more that, older adults in the 50s are. So, and then remember, no seasonality, right? So it can happen at any time. It's usually reactivation. It doesn't really happen with primary HSV infection as a manifestation of that, as opposed to like other infections, right? That maybe like whether they're neurotropic or not, and whether it happens right when you first get it. This is seems to be more of a reactivation.
Is there any age group that's more common to get the autoimmune encephalitis? Is it like more common younger or older?
There's no age group that has been specifically, there's so for autoimmune encephalitis, HSV, there's not specific, but there's definitely a higher female to male ratio for anti-NMDR for sure. Like by a lot. Like some studies say 4 to 1, 8 to 1, and some studies for post-infectious autoimmune or for autoimmune encephalitis in general. Definitely a higher female prevalence, and you do tend to get some younger adults just with the autoimmune encephalitis. All right, so this is I just wanted you guys to look at this, right? So herpes simplex comes in, and there's retrograde migration. It establishes itself there. So when you're looking at this diagram, what kind of things would you say would increase your risk of getting like an HSV encephalitis? Just by looking at this sort of pathophysiology.
Instrumentation.
Yeah, we talked about that last month, right? One of the many cases that you just treat empirically because no one's getting an LP. So yeah, if you think about anything that could disturb surgical or neurosurgical procedure that could mess with the nerves involved here, right? That could facilitate entry into places that, or the stress involved with that, right? So, most of these are asymptomatic, as you guys know. Actually, I'm going to skip all that. So, all right. So basically, altermentation, rapid onset of fever, headache, seizures, and then focal neurologic signs. You can have focal cranial nerve deficits, as you guys know, hemiparesis, dysphagia, even urinary and fecal incontinence. It can present in a lot of different ways. The behavioral syndromes are always cool. You guys remember these, I'm sure, from med school, maybe residency. But like, I think you had mentioned to me. Yeah, very familiar with that. So psychic blindness. You guys heard of that terminology before? Lots of normal anger and fear responses. Huh? Yeah, that makes for a fun person, probably. Right? Yeah. Let's go. This woman wants me. Is that baseline? Just kidding. So, and hypersexuality. So, varying states of amnesia, all of these sort of things. So, really, when my first few cases as a fellow, I just remember anything that even remotely sounded like this bizarre behavior, like their family members saying, oh, they were fine one day, and then the next day they're like up all night doing things I've never seen them doing before. One of my patients was like this like really faithful married man, and suddenly was out like with prostitutes and like just really bizarre behavior. I mean, bizarre in the context of whatever your baseline is, right? So, or like, our guy that we had, he was post neurosurgery, and the daughters were saying that he was like outside in his driveway, and we never got a diagnosis, but just things that kind of stick out in your mind. Outside in his driveway, peeing outside, like, which he had never done before, right? So just kind of things that they used to act like this, and now they're acting in all these other ways. All right, so necrotizing temporal lobe encephalitis. So this is one where like imaging and other things could help you. Sometimes it doesn't show anything, but and then that's one of the biggest things, is that there's a lot of atypical presentations, ischemic stroke, hemorrhages, other things. Risk factors, whole brain irradiation, and neurosurgical procedure for some of the reasons we mentioned. And then it can present in very typical ways. So it's just really, a lot of these are just really hard to diagnose. But the main thing is just, if you even think about it, give them acyclovir. This is what their labs may look like. So increased protein, you guys know it's lymphocytic predominant, but you can have neutrophil predominance really early on at times, and then it switches. That happens with a lot of these. And then just remember it can present a little different in immunocompetent, where it may not read everything. And then you guys know increased erythrocytes are kind of a thing with HSV. We talked about repeat testing. If the glucose is low, think about something else. Okay? All right. Imaging, I'm not going to go into this too much, but basically you guys know it'll light up in the temporal lobes, mesiotemporal, maybe orbitofrontal in some cases. And then EEG will show these delta and theta slowing, so amplitude, high amplitude slow waves. And then this is all lookup stuff, but just so like you've seen it. And then continuous periodic lateralized epilepsy. You may or may not have seen that in some of your patients, right? Sometimes it's super classic like that. All right. And then, like I mentioned before, universal agreement in domestic and international encephalitis guidelines. And if there's a high suspicion for herpes simplex encephalitis, give them IV acyclovir, even if their HSV1 PCR is negative. And then you're supposed to repeat a CSF sample 3 to 7 days later. We killed that, I think, right? You guys got that? Reports of patients, I like this. The reports of patients with multiple negative HSV1 PCR tests on sequential CSF samples have ultimately been confirmed on autopsy. So that's really helpful for clinicians, right? Like, yay, everything's negative. So again, if your clinical suspicion is high, if anything even like smells like it, start that acyclovir. All right, and then this is, I just wanted to show you what this looks like. You guys know. Somebody mentioned on one of the questions about, I think somebody answered acyclovir resistance. Is it a possibility? It is a possibility. It's very, like, I think it was like less than 3%, 3 to 5%. Granted, this is in the normal population. Immunocompromised patients that have been on acyclovir prophy for obviously then that's different. And then you would use Foscarnet, and then I don't want to get into all that, but other risk factors, if you even see this word anywhere in the patient's chart, yeah, for sure, right? So especially like patients with MS, think about like the perfect storm. You're blocking T lymphocyte migration into their CNS. It's going to increase their risk a lot. So if you see this, and then TNF inhibitors also increase your risk. So despite acyclovir therapy, mortality remains pretty high. Without acyclovir, it's almost like 40 to 50%. And then even when you do everything right, neurologic or cognitive deficits can persist. Again, this is why we're going to beat this one to death. These are some of the poor prognostic. Age greater than 30, Jesus, right? Yikes. Yeah, I mean, all right, so what is one modifiable risk factor? What is the one modifiable risk factor out of all those poor prognostic factors?
How quickly you start the acyclovir.
Thank you. All right. Starting empiric acyclovir is the one thing that we can actually do to make a difference until it has definitively been excluded, which we know is almost impossible. Yeah. All right. So other pathogens of importance, we're just going to touch on these really short. So you guys know BZV. So this is the second leading cause of encephalitis in adults after HSV1. It's more, definitely immunocompromised patients are affected more, also due to viral reactivation. The CNS manifestations can happen, again, before, during, or after you have the shingles or zoster lesions, right? And then how cool is this? Because it's just, everything needs to be more complicated for us. So you can have the BCV encephalitis without the typical skin findings ever showing up on the patient. This is up to 1/3 of cases, right? So you guys can, I like saying that, but I'm not good at saying it, so I'm not going to say it.
So this is kind of like unlike HSV. It's typically.
There's some history of some kind of dermatoma zoster in immunocompetent patients. Yeah. But again, 1/3 of patients may not, right? So, and then this can present as a vasculopathy, and that is sort of one of the bigger things if you see like rule outs for strokes. So ischemic or hemorrhagic strokes. I had one of my friend's moms actually presented with this stroke syndrome, and she had all these thromboses everywhere, and she doesn't really have a lot of risk factors. So we were like wondering how could one person have so many, she had cerebral venous thrombosis, she had like cavernous sinus, she had a few different spots, spinal artery thromboses. So this is something that you need to be thinking about if these sort of alternative presentations like that. Vaccines. So yeah, the epidemiology of VZV has shifted, encephalitis shifted with the introduction of the varicella vaccine. So this is kind of a sign for the times, right? Who owns a dog? Everybody has dogs. So your dog is required to, before you board your dog anywhere, you're mandated everywhere in the state of Florida. You're mandated for your dog to have vaccine records and have all these vaccines and show up, and you can't board your dog anywhere without your vaccine records. Your kid, on the other hand, all good there. All good there. So if you're so those vaccines work. Am I gonna get fired? Huh? Yeah. Well, anyway, so I guess this is just gloom and doom. This changed, but some of these things may be coming back, obviously, as you guys know. These are some of the other ones that are, so enterovirus encephalitis, I would argue, is sort of the third one most common that you guys may encounter as far as these universal pathogens. It's definitely the leading cause of pediatric encephalitis. You look for skin or oral lesions, hand, foot, mouth disease, herpangina, all of those things can clue you into the enterovirus. It's really hard to diagnose. The PCR and the CSF is not great. So people start testing all these other sites, but then it's like correlation versus, it's really hard to prove. So you really have to have a high index of suspicion. And then this enterovirus A71 is actually very aggressive and high mortality, whereas most of the other ones tend to present like mild without all these other horrible things that happen with the ones I mentioned before. EBV encephalitis, not as common either. I really only put this on here because how cool is this? Alice in Wonderland presentation with metamorphosia. Have you guys heard of that before?
What is that?
So Alice in Wonderland, you guys are familiar with the movie and all the different ways you can watch the movie. Perception of distorted shapes and sizes. It can localize to the cerebellum. So I don't know how you get that history, but but something cool to know, huh? Is that clock on the wall?
Yeah.
What geometric shape is that? And they're like, fuck out of here. I'm sick.
Does the whole world look like a Salvador Dali painting?
That's a good one. Sir, are you familiar with surrealism? The surreal period in art? Anyways, let's keep going. We're doing great. All right. Who wants to read this one?
A 27-year-old man is hospitalized for a 2-day history of fever, headache, and a 1-day history of left lower showing weakness. 10 days earlier, he returned to Idaho, involving rafting and sleeping outdoors. No known tick bites. On exam, 39.1 Celsius. Blood pressure is normal. Heart rate 118. Respiratory rate 28. He's oriented to place and time. mild knuckle rigidity, left lower extremity weakness, inability to flex or extend the knee or ankle. Deep tendon reflexes were absent, and sensation intact, no rash. His CSF studies, leukocyte count of 256, glucose of 55, protein of 299, and MRI, no focal abnormalities.
Go back to the. Okay, yeah, I have grounds.
Yeah, West Nile antibody. Yep, West Nile antibody.
Which antibody is it?
West Nile.
But which one?
Oh, IG.
M. Yeah, just want to make sure. All right, awesome, great. So again, if you're gonna get tested on any of these, there's so many of these, and for you to remember the regions of the U.S., which most of them are in the Northeast, is gonna be really hard. They're really gonna ask you about West Nile, right? Powassan is up and coming. It's a tick-borne disease. This is like on board questions. If they tell you no tick bites, I guess you got to take their word for it. Whereas in real life, that doesn't make sense because nobody knows when they got a tick bite. But Powassan is tick-borne, so you can say, okay, so they're trying to tell me that this isn't a tick-borne thing, whereas the other ones are mosquito. And yeah, but the most common by far is going to be West Nile. And then, so you guys know that CSF IgM is the right answer here. And then I'm gonna ask you why and tell you why in a little bit. So basically, leading cause of epidemic encephalitis. Again, this one does have seasonality. So when you're thinking of patients or taking test questions, think about that. Most of them are asymptomatic, and then a certain amount in the population will develop symptoms, and they can manifest in any of these ways. And again, they're maybe picking these up because these are the sickest patients, so we're doing more testing, right? And then these are your sort of risk factors for it. All right, male sex is a risk factor there. Lymphocytic pleocytosis, elevated protein, your glucose is going to be normal. It may be absent, pleocytosis may be absent in up to 5% of cases. So these are our guidelines, and doesn't it make you question everything we do? I mean, if somebody's really meets criteria, when you go back to your major and minor criteria for encephalitis, and you're looking at this, because let me tell you, everything gets canceled after no white cells in the CSF, right? And for meningitis, that makes sense, but for encephalitis, that may not make sense, right? So then you got to fight with the lab. And then again, CSF IgM is your test of choice. PCR has less than 60% sensitivity. When you're looking at neuroimaging, it's gonna be your basal ganglia temporal lobe. Sort of, this is what it may look like. All right. So why is it that we do the CSF IgM and not a PCR?
Yeah. So the PCR peaks earlier. So by the time the patient presents with symptoms, they're probably no longer viremic. So the test of choice is the IgM.
Nailed it. Perfect. Exactly. So with West Nile and a lot of the other arboviruses, your viremia peaks and then you develop symptoms. So by the time you're symptomatic and presenting somewhere, your viremia is already barely detectable. So that's why you get the CSF, right? Because it's a little, for most other things, you get your PCR because that's the most sensitive test. So I just wanted you guys to know the background on that. Yep. Okay. What is one exception to this?
Exception to what?
To where your IgM antibody in the CSF may lead you astray.
Oh, well, I mean, there could be,
when you're trying to diagnose West Nile.
I mean, there could be cross-reactivity with other arboviruses.
Meaning more as a function of what will not make this test a good test.
Oh, if you get yeah,
there you go.
Or
so thinking along those lines, what's going to make me not make antibody IgM in my CSF, right? So, and these are typically the patients that are even a little higher risk, right? So,
right.
Yes, Rituximab, exactly, and that goes for anytime you're trying to pick up an antibody
So
response.
like, could IVIG give you like a false positive?
And IVIG could potentially give you a false positive. So yeah, anybody with an impaired, you guys answered all of these. Humoral response. Anybody that got rituximab, and you guys know the half-life of that, it's so long, so it lasts forever. All right, and then now, what is an exception in reverse? I don't know how to ask that question.
So, what are you trying-
What in the world is she trying to ask? Yeah. Assistant to the regional manager. Backup to the backup to the backup. All right. So basically, if it's VZV and it's a stroke syndrome that we talked about, then your antibody may actually be more sensitive than PCR. One exception, and that's based on the how it's infecting and how long it takes, and how your PCR may not be playing a role, or your viremia may not playing a role. Okay, next question.
33-year-old woman who had in January with a 3-day history of fever and stiff neck and she was previously well, and medical history was negative for recent travel. She takes no medications. On physical examination, temperature is 113, blood pressure is 136, pulse is 100, respiration rate is 18. The general medical examination is unremarkable. On neurological examination, she shows photophobia, non-dilated fundoscopic examination shows no papilledema. Remainder of the examination is not vocal. CSF shows a leukocyte count of 324. Leukocyte count of 324 with 60% neutrophils, glucose of 58, and protein of 125. Gram staining is negative and culture remains pending.
I hated this question too. Sorry.
Wait, so you said it?
I'm guessing this is January.
January.
They want to go for then they want to go for.
Yeah.
Sorry, but I'm missing like time frames.
Enterovirus is more in the summer, right?
Yeah.
So what can you subtract or scratch out?
West Nile.
Yeah,
Probably not mumps.
probably not mumps.
I think it's most likely HSV too. Yeah.
Depends. Are we in West Texas? Just
Yeah.
how old is this person? So what's the final answer? You guys already.
HSV too.
Yeah. So this is all about, do you know the seasonality of these things? Which one can last throughout? It's still, they gave you neutrophil predominance, which is even trying to confuse you even more. Glucose was normal, so you're thinking about, But yes, it's all about seasonality. So the cutoff for enterovirus is like October, November. If things read the book, climate change is changing everything, right? So it's like everything I say is, I could be arguing, to the contrary. But that's what they want you to know. All right, so this is just a little summary. So May to November for enterovirus. Herpes Simplex 2 is the most common outside of this, the EV time frame. Relapsing. On presentation? So this is more, so the one thing I will say that's a really good question is this sounds more like what's your syndrome here? More of a meningitis, whereas your HSV1 is going to be more of an encephalitis presentation. Yep, that's a good question. All right. Again, and I say that there. Seasonality, VZV, do you have the dermatome? But remember, it can present without it. But your board questions are going to make it a little more simple. It's just not as simple in real life. And, measles is making a comeback, and you guys correctly asked if they were immunized. So mumps, measles. And then these ones in the bottom are more of an immunocompromised patient. All right. Again, just because I'm trying to hurry. All right. 36-year-old man on a hiking trip in Northern California gets bit on the lower leg by a skunk. Upon presentation, They didn't smell it coming. Upon presentation, he's afebrile and several puncture wounds on the right lower extremity. You irrigate wounds with soap and iodine and administer tetanus booster. What do you want to ask this person? Thank you. All right. They say, yeah. I have never been face to face with a skunk. So, yeah. So what do you do? What do you need to do?
I think you need to make a fun one for the cure for rabies.
Don't worry. Our domestic animals have to be vaccinated. It's only people we don't care about.
Irrigate the bite that, yeah.
So I lost my audience. I'm just kidding. No, it's fun. Yeah. So the final answer is
Hey.
Okay. Let's keep going. So this is all they're gonna ask you about rabies on the boards. PEP, post-exposure prophylaxis. So know this well. Yes. So in addition to administration, yeah, but you're correct. You must give the vaccine. They're immunocompromised. It's 5 doses, just instead of the 4, right? So that's one thing to remember. If they've been vaccinated, then no immune globulin. You get vaccines days 0 and 3. Try to remember who was with me when our patient with the pet raccoon. Oh my God, it was the cutest thing. I fell in love with raccoons after that. The raccoon was doing all kinds of things, like eating chicken nuggets or playing with this or like building a Lego set or like all the pictures. I was kidding about the Lego set. So, all right. And so this is a map of the news stations that people in the States and what news stations they prefer based on geography. Just kidding. So this is the animals that where is more predominant. So if you're going to get rabies, by the way, the another possible test question would be, there was a bat somewhere in somebody's room, right? And then the answer is rabies. In the U.S., what's the most common cause of rabies in the world? Dogs. Yeah, by far, like 90% or higher. In the U.S., because of and we even like throw rabies vaccine out in the wild, so our animals are vaccinated passively like that. So, but yeah, I just thought this was a fun map. Mongoose.
That's the funnest part.
Mongooses?
Yeah. That's
What's the plural? What is the plural? What is the plural for mongoose? I think I taught you guys somebody who the plural for octopus, because it's not what you think. It's octopuses. You can Google that. Okay, moving on. Sorry, let's go. So this paper, if you guys look into a lot of the charts which I put on here, the rest of the stuff you're going to be guided, right? The things that fall outside of these universal pathogens are going to be guided by, do they have an eosinophilic pleocytosis? Do they have this? What's happening in their blood? Do they have a thrombocytopenia, leukopenia? What's their epidemiology, right? Where did they come from? What are their possible exposures? And then you start deciding what else you're going to add to your testing, right? We'll go into this a little bit more later, but so boards like this eosinophilic pleocytosis, Bayless ascaris, and what is the definition of pica? You guys know? How do you define pica?
Things that are not food.
Non-food items. Baking soda, talcum powder. It's very odd, but poop falls into that. So if they mention that ingestion, like how else would you? We're like, Oh, did you ingest raccoon feces in the last 2 weeks? Right? So you can't. So you just have to sort of ask about other possible conditions and what those conditions may be associated with, right? And do you indulge in non-food items? And these are actual conditions, like either medical conditions or mental health conditions. So just try to get a history of that. All right. Then your radiography can help you in different ways, right? Frontal lobe involvement, Naegleria fowleri. You would also get the shallow water, diving into shallow water, warm water. History, obviously temporal lobe we talked about. When we think about a rhomboencephalitis, right, when you're just trying to localize, listeria is what's going to come up there, and that's a brainstem involvement. If you have actual stroke presentation, ischemic lesions, VZV, syphilis, tuberculosis, right? So the imaging can help you. I'm going to skip through all this, but we may be able to come back to this. So this is a case about, I'm going to skip it because I want to get to some of these other ones. All right, let's see.
Can I just add real quick about your pica? It's wonderful. Just learning disabled children.
Yes.
That's also important.
Yes. Yeah, it's been associated with autism disorder. It's been associated with a lot of. Oh yeah, it's okay. I'm gonna. I have some time, right? I still have. Right. Then the neti pods. Exactly. All right. So 29-year-old woman evaluated in the ER in January. 5-day history of fever, severe headaches, delusions, paranoid behavior. Medical history is non-contributory. She has a mild temp. Vitals are relatively okay. Neck is supple. Chorioathetoid movements, bilateral upper extremities. She has a seizure in the ER. What more can you ask here? Lymphocyte predominant. Glucose is normal. Bacterial and fungal cultures are negative. PCR for herpes is negative. MRI is normal. What is this? Why? Yep, that's what gives it away, right?
Young female.
Young female chorioathetoid. Okay, that's what that is. It was only described 15 years ago. It's a relatively new thing, right? So autoantibody mediated encephalitis. If you see orofacial dyskinesias, myoclonus, or these chorioathetoid movements like were mentioned, that would give it away. They can progress rapidly into status epilepticus, right? So the fact she had a seizure in the ER, like I said before, high female predominance. The other way they can ask this, and then half of the cases occur as paraneoplastic syndrome. That was the biggest thing when it first started to be described. So the other way they may ask this question is they may give you something similar, and then they'll tell you, like, what's the next step? Like, how do you make the diagnosis? And then what would be your answer? Or like the
Imaging.
transvaginal ultrasound. That's another way of seeing this question asked. Yep, because it's related to ovarian teratomas. All right, we'll keep going. And then this is how you treat it. Steroids, IgG. If they fail those things, then you start trying second and third line therapies, which is Rituxan, cyclophosphamide. I'm going to keep going here. This is super easy. Let's just knock it out. So ER antibiotic, 44 patient with in health. Okay, yes, change is great. So these are your cause of bacterial meningitis. You guys are really familiar with this. So I'm going to keep going. Things to know. I like this mnemonic. Is this a mnemonic? I get my English words.
Yeah.
So you were asking about this. When do you get a CT before LP? You guys familiar with these criteria? Okay. So fails, focal neuralgia, altered mental status, immunocompromised, or increased any sign of, so you're supposed to look in their eyes. And then any known history of CNS disease or new onset seizure. All right. So Obviously, we know why, right? You don't want to herniate the person. We're removing too much. And then this is just the main thing I wanted to show. Adherence to IDSA guidelines when it comes to doing a CT. Identified all patients with major intracranial abnormalities. So just following those fails criteria. Okay. I'll come back to that one. This is something you need to know, right? So chemoprophylaxis. Who gets chemoprophylaxis? Huh? What? He always gets the call?
No, I actually took it. Yeah.
And the gram thing said.
Oh, I know. I'm familiar with that. It was Staph aureus.
And it was tough for it. Yeah, the next day.
Yeah.
Fernando got a dose.
So, one learning point about that case, and I brought this up later when we were discussing, Danaher and I were discussing the case, I was like, I would not have given people quinolone prophylaxis because that particular gentleman had been on Levaquin for like a week prior to his presentation.
True.
So there's data that says you could have quinolone resistance in those particular cases, and you should choose an alternative agent. Yeah. So, yeah. But yeah, the most important thing is to remain calm, right? So, I know that's what happens to the VA. So these are guidelines, and then literally everyone on the floor gets chemoprophylaxis. Okay, I'm gonna keep going. Steroids. Who gets steroids? Okay, once strep pneumo is ruled out, you stop the steroids, and you have to give it before antibiotics, otherwise it's pointless. Let's keep going. Okay, this is a good one. Let's go.
Fever, headaches. Then he immigrated from Mexico. 60 neck flexion, and this is painful resistance. CFF analysis reveals leukocyte count of 404 with 92% lymphocytes. Glucose level 22, protein of 278. Rapid point of care antibody screening for HIV is negative. CSF gram stay on critical antigen test results are negative. Results from the cultures with CSF and blood and the interferon gamma release assay.
Yeah. All right. What stands out here?
Lymphocytic predominance, low glucose, elevated protein.
Okay. What?
From Mexico.
So what is this?
TB.
And they mentioned the
Hell yeah. Huh?
And they mentioned the egg for some reason.
Yeah, I know. Okay. Thank you. You're like, could it be this easy? On the boards, and then you're like, oh god, is it too easy? Is this wrong? And then those are the ones you overthink. Okay, so what's the answer?
Right, plus dexamethasone. Use it for TB meningitis as well.
Read the case.
So the correct answer is C. I don't know why I didn't letter these, but all right, so this is TB meningitis. Once you see one, I had one with Dr. Araba, you never forget. And it's very difficult to diagnose, extremely difficult to diagnose. So these are your chronic meningitis bugs. This is how you decide subacute versus chronic. At least for infectious causes, right? Your differential can include other things. So TB meningitis, how do you diagnose it? You guys know?
It's a combination of like clinical diagnosis, like you need to have like clinical suspicion,
Mm-hmm.
and then suggestive CSF findings. But like culture's frequently negative.
What was a little different about this CSF from your typical? Yeah, so high lymphocyte predominance,
Very
glucose was low, and your protein was super high, right? So that's a little different, right? And again, they're not all going to present this way, but that's sort of the, how often do you see that, right? And then, but what do you send out? Yeah. Yeah. And then you just beg the lab. I know this isn't an approved site, but I need to make this diagnosis. Yeah, and so the key is repeat CSF, high volume CSF, and testing and sending multiple AFB cultures. But most of the time, it's a clinical diagnosis, right? The guy came from Mexico, he's got this, he's got that. And then there's other things that can help you. Like, what would the imaging look like, for example? Yeah. So what? What else? What else is a big one that happens? So I'll show you in a minute. Always get a chest X-ray if you're suspecting it, because you may pick it up on that way, by the way. Okay, and then like, as you guys mentioned, you can run the PCR, and that's the most sensitive test while you're waiting for cultures. This is some guidelines, some index that you're supposed to use. I was like, when I first saw this, I was like, wait, -5, +4? Okay. So you want to score less on this test? I mean, you want to score high on this test as opposed to most other things that we have. But the lower the score, the higher it's. I don't think these are helpful, to be honest, but this is just so you've seen it before. It's one of the indexes that are so. So this is one example of what TB meningitis may look like. What is this showing? And hydrocephalus, right? You can see all the like ventricles, like super. Okay. Yeah. And then, so you guys already said a lot of this, but third ventricle hydrocephalus, you see that. A lot of edema. All right. This is the basal exudates. So they describe it as sort of like spider webby, right? You can see that. It sometimes looks like a lot of pus when you're looking at it, honestly, like, right? And then what are we showing here?
That looks like
There's definitely a drain there.
Midline shift.
Yeah, so a stroke, right? So we mentioned that TB is one of the ischemic stroke presentations, right? A lot of edema. I mean, you really have lost all. So, okay, so those are your possibilities there. Treat with drug, like we said, right? RIPE, dexamethasone. So a lot of some data for randomized controlled trials showing a mortality benefit with glucocorticoid by adding the glucocorticoid therapy. When they assessed this in HIV positive patients, it didn't quite show up mortality benefit, but we're still doing it whether the patient is HIV positive or not. And then the main drug here is INH as far as your CNS penetration, right? Whereas for TB, rifampin is usually the most important drug, right? And then there's some data about fluoroquinolones to increase penetration, but some of it is controversial. So you do the RIPE plus Dexa, but maybe if your patient's not improving. All right. And then some other causes of chronic meningitis. I don't know. I heard noise. Okay. Okay. We talked about some of these, but basically, the diagnostics on crypto are pretty good, unlike some of these other things we've mentioned. The endemic mycoses, any of them can give you a chronic meningitis. Blasto is less likely to do that. You're higher risk if you're immunocompromised. And then these are some of the other bacterial, and then you may have other historical findings that can help you, right? So like for Trophoma whipple GI symptoms, or getting more history may help you in these particular cases. All right, and then I mentioned the types of eosinophilic meningitis, just the one that, like I said, they like testing on, which is the ingestion of garbage or raccoon feces, right? Number 4. And then You guys are familiar with Naegleria. Again, diving shallow lakes, going up the nose to cribriform plate, right? And rapidly progresses. Neti pots was the other thing. There's been reports in like water parks for kids, like splash pads, all of that, right? So if they mention snails, ingestion of snails or slugs and Strongylus. So just so you guys have seen some of these eosinophilic meningitis. And then almost done. This is the last one, I think. So healthcare associated meningitis, we get a couple of these every once in a while, right? And I always teach you guys where is the most likely, right? You got a BP shunt. What's your risk? Where is the most likely, right? You have this part, and then you have the peritoneal, ventricular, and the peritoneal. So you can figure out what bugs and what mechanisms based on that, right? So what's the site that's most likely to get infected?
Peritoneal.
So it's actually this site initially, and for some time, right? So this is the wound. This is the wound that sort of stays open, right? So until this completely heals, this is sort of your most likely portal of entry. And we're talking about skin bugs or nosocomial bugs, right? Because you had a procedure. So nosocomial bugs are Staph aureus, Pseudomonas, skin bugs, right? Now, when this is completely healed, right, and you're done, and 10 years later, your patient comes in with something that looks like they could have a VP shunt-related infection or ventriculitis meningitis, then this can become more of a role, right? Because this is now a little bit more exposed to what kind of infections. Yeah, so you would get more of like a secondary peritonitis type of presentation, right? So what can cause a secondary peritonitis? Right, and I mean secondary as in it's not SBP, right? It's not spontaneous bacterial peritonitis. What else? Yeah, perforation. Yeah, maybe some biliary infection that ascends that get, yeah, GI surgery, a perforated diverticulitis, even if it's contained potentially, right? I mean, so, and then what do you usually see at the tip there? Of the peritoneal aspect of the shunt. So if you see this could help you with the diagnosis. Yeah, like a cyst, like a pseudocyst, and you'll see that described. So, and then what's the treatment?
Replacement.
Yeah, get it out. Right, it's a prosthetic, so it's going to be hard to. Yeah, so that depends on how dependent the patient is on it.
External.
And then it becomes like, do they need an external, like a temporary external drain, et cetera, et cetera. And then this is the last thing. So this is, I don't know if you guys have had a different experience. EVDs, it's like they get infected. It's hard to prove it, but you know they get infected. CSF studies don't help you. The cultures don't help. That's been my experience, anyways. Oh, is this colonization? Is this real? Is it all right? So, if you're suspecting it, the best thing to do is to remove the drain. All right. Brain abscess. I'm gonna end. These are your main mechanisms for brain abscess. Any questions on anything?
Fine. It's been in place for a long time, but he had cholecystitis. He had like a cholecystitis, and he did a coli, lap coli, a little bit of spillage bile. They're like, what antibiotics? How long does he need?
To protect the shunt, or yeah, that's the art.
Yeah, I
know. Yeah, I mean, continue. Yeah. So, but they took the gallbladder out. So it's source control. Yeah. Yeah. And so that becomes a problem of, did something seed the shot? And you're not going to know until later. And giving them antibiotics may or may not help, because once it's on it, the only way to get it out. Yeah, the only way to get it out is to get it out. Exactly. Right. So technically, you achieve source control. Give them a little bit of antibiotics and say a prayer. No, because if it's seeded, then it will manifest eventually, no matter. So.
Why do we stop steroids after?
Because
Is the benefit only
correct. So on the studies, it only showed benefit specifically for strep. Yep.
I think you for adults.
You can actually increase mortality. Yep.
It can worsen mortality.
I think there's also mortality for pediatrics with each flu, but for adults, it's only for strep.
Yeah.
Whew.
Good job.